Hi guys, today I'm going to be discussing about Klumpke's paralysis is a lesion of the brachial plexus. It's a lesion to specifically the T8 and C8 and T1 roots, and the main nerves involved are the ulnar nerve and the median nerve. So how we can understand this is C8 and T1 join to form the inferior trunk, which then divides into the posterior division and the anterior division. The posterior division joins with the other posterior divisions of all the other trunks to form the posterior cord, and this gives rise to mainly the axillary nerve and the radial nerve. While the anterior division continues as the medial cord, and this then gives a branch that joins with a branch of the lateral cord to form the median nerve, and then it continues as the ulnar nerve. It also gives rise to the medial cutaneous nerve of the arm and medial cutaneous nerve of the forearm. So, this C8 and T1 roots do give a contribution to the posterior cord and thus do contribute to the axillary nerve and radial nerve. However, the axillary nerve and radial nerve are not much involved because it receives contribution from the C5, C6, and C7 nerve roots. However, you can see the ulnar nerve, it only receives innervation from the C8 and T1 roots, and the median nerve also receives mainly innervation from the C8 and T1 roots. C8 and T1, after it forms the medial cord, it gives rise to the median nerve and ulnar nerve, and medial cutaneous nerve of arm and forearm. So therefore, these nerves contain much more innervation from the C8 and T1 roots rather than the other nerves. So let's understand its presentation. How the injury happens is normally due to undue abduction of the arm. This happens if someone falls from a height and, like for example, if they fall from a tree and they try to grasp onto a branch, then the weight of the body pulls on the neck and the arm, and it causes stretching and injury to the lower nerve roots, which is C8 and T1. So the deformity caused is mainly extension of the wrist, extension at the metacarpophalangeal joints, and flexion at the interphalangeal joints. We can understand this because the median nerve supplies the lumbricals, and the lumbricals cause flexion at the MCP joints and extension of the interphalangeal joints, like this. So when that is weakened, it results in hyperextension of the MCP joints and flexion at the interphalangeal joints, thus causing claw hand. And there's a complete claw hand because both the median and ulnar nerve is affected. The median nerve only supplies the lateral 3.5 digits, and the ulnar nerve supplies the medial 1.5 digits. But since both of the nerves are affected, all the digits are affected, and there's a complete claw hand. There's also supination of the forearm because of the weakness of the pronator muscles, which are namely the pronator teres and the pronator quadratus, which is also supplied by the median nerve. There's extension of the wrist due to the weakness of all the flexors of the wrist, which are supplied by both the median and ulnar nerve. There's cutaneous anesthesia along the medial or the ulnar border of the forearm and hand. And if you remember, the medial cord gives rise to the medial cutaneous nerve of the arm and forearm, which gives cutaneous innervation to the ulnar border of the forearm and hand. One more thing is, as you know, the T1 root gives rise to sympathetic fibers. The lateral horn of the T1 segment gives rise to sympathetic fibers, which along the white ramus communicans travels into the sympathetic ganglion, and from there it ascends up to the superior, middle, and inferior cervical ganglion, and then through the gray ramus communicans it exits and innervates the head, neck, and the rest of the body. So if the injury is proximal to the white ramus communicans, then the sympathetic fibers of the entire body is affected. So this can cause ptosis, meiosis, anhidrosis, anophthalmos, and loss of ciliospinal reflex. But if it is distal to the white ramus communicans, then only the sympathetic fibers innervating T1 is affected. So this can result in warm skin of the T1 dermatome due to arterial dilatation, and dry skin because of absence of sweating. So let's discuss what the median nerve supplies. In the forearm, the median nerve supplies flexors of the wrist, and these are divided into superficial muscles and deep muscles. The superficial muscles include flexi carpi radialis, palmaris longus, flexor digitorum superficialis, and the deep muscle is flexor digitorum profundus. All of these muscles flex the wrist. It also supplies pronator muscles, pronator quadratus and pronator teres. It also supplies flexors of the interphalangeal joints, and flexor digitorum superficialis and flexor digitorum profundus flexes the interphalangeal joints. Flexor digitorum superficialis flexes the proximal interphalangeal joint and the MCP joint, and the flexor digitorum profundus flexes the distal IP joint. It also supplies the flexors of the thumb, which are the flexor pollicis longus and flexor distal, and which flexes the distal phalanx of the thumb. And it supplies the muscles of the thenar eminence. These muscles cause the various movements of the thumb, such as abduction of the thumb, opposition, flexion of the MCP joint of the thumb. So all this provides grip to the thumb. And most importantly, it supplies the lumbricals, the lateral two lumbricals, which flexes the MCP joint and extends the IP joint. So the median nerve supplies all the flexor muscles of the wrist. So therefore, because of the weakness of these flexor muscles, the extensor muscles of the wrist contract and unopposedly, and they cause extension of the wrist. It also supplies the muscles that flex the IP joints. So one would expect, due to the weakness of the flexor muscles of the IP joints, that the IP joint should be in an extension position. However, an important thing to note is that the lumbricals, so the flexors are weak, so it tries to assume an extension position. However, lumbricals are an important muscle for extension of the IP joints. So the extensor muscles in the forearm, their tendons extend and insert into the phalanges of the fingers to cause extension. However, lumbricals there's a extensor hood, connective tissue that expands over the phalanges of the fingers. As you can see, this is the tendon of the extensor muscle, and this expands to form an extensor hood. These lumbricals and interossei muscle, they insert into this extensor hood. So they kind of pull on this connective tissue to really cause extension. So they are the main muscles that cause extension. So although the weakness of the flexor muscles may cause the fingers to assume an extension position, the extensor muscles try to extend the fingers. However, the lumbricals are very weak too, so they go into this claw hand position with flexion of the interphalangeal joints. And there's also loss of grip of the palm of the hand due to weakness of all the muscles of the thenar eminence. The ulnar nerve supplies the medial flexors of the wrist, such as flexor carpi ulnaris and the medial half of flexor digitorum profundus. In the hand, it provides cutaneous supply over the skin of the hypothenar eminence, and it provides innervation to adductor pollicis, palmaris brevis, muscles of the hyperthenar eminence, the third and fourth lumbricals, and all the palmar and dorsal interossei. And the palmar and dorsal interossei also have the same action as the lumbricals, which is flexion at the MCP joint and extension at the IP joints. So you can imagine, due to the weakness of both these muscles, which are very integral in extending the IP joints, there's inability to extend the IP joints, and it goes into a kind of semi-flexed position. There's also weakness of the muscles of the hypothenar eminence due to the lesion of the ulnar nerve, which supplies these muscles. So again, these also contribute to the grip of the hand. So that's affected due to this.